Welcome to Episode 14, Impact of Implicit Racial Bias with Clients of Color, by April Tith, licensed marriage and family therapist. From Clearly Clinical, learn, grow, shine.
Greetings, everyone. My name is April Tith, and I'm a licensed marriage and family therapist. As you might already know, the training content that I'm providing in this course focuses on the impact of implicit racial bias, primarily in mental health settings. So I'd like to start off just by emphasizing that this isn't really a lecture or a training, but more of a discussion. It may be a one-sided discussion by nature of being a podcast, but I would really encourage that as you listen to some of the topics that I go over, that you might want to take notes on really anything that triggers you, whether that be a client situation that I bring up, a difficult topic that maybe you don't agree with, you hear something that you think is a bit controversial, or maybe just a discussion point that you'd prefer not to think about because it makes you feel uncomfortable. Those are all really important things to recognize within ourselves, and I'll kind of get into that a little bit more. But again, as we go over this content, really the whole point is to be aware of, really what our internal process is as we kind of go through these sorts of situations when dealing with clients and maybe even in our own personal lives. Really, our feelings of avoidance, discomfort, anger, frustration, maybe sadness, they're all examples of, what we often try to avoid, not just in clinical practice, but as I said again, also in our personal lives. And the reason that delving into difficult topics like implicit racial bias and cultural bias is so important is because if we don't address it for ourselves, then we fail to recognize, consider, and validate these feelings and struggles with our clients. So my hope is that you as practitioners will be able to utilize some of these strategies in your own practice or work setting to engender constructive and effective discussion with both clients and colleagues, as well as maybe some of your peers as well. So with that, I'm going to briefly describe the objectives for the course. I know these may be stated elsewhere, but I'll kind of get into each and every one of them and elaborate further about why they're important. So upon completing this course, participants should be able to firstly define and distinguish between the concepts of cultural competence versus cultural humility and their respective impacts within clinical interviewing and client care. I will say off the bat, that there is overlap here. Again, cultural competence and cultural humility both are, constructs that have evolved over the past several years. Generally, they're new topics. They're new in terms of the research, in terms of the implementation within mental health, and they're constantly changing. But really, I want to get into a discussion about what some of the differences are, how researchers as well as clinicians, have kind of adopted both mentalities, how we've implemented them into our practice, both successfully and unsuccessfully. And that's really the point here. Secondly, another objective is to define and distinguish between the concepts of bias versus implicit bias and the implications of both when working with clients and more specifically with clients of color. And lastly, identifying at least one strategy for integrating and maintaining cultural self-awareness in clinical practice. And so on that note, I really wanted to take a second too and again, just kind of have a bit of a reflection moment, and might be doing that a couple times here just because, again, I think it's so important to just be mindful and self-aware of our own internal process, because again, that is really the way to progress with our own cultural mindfulness. And so I wanted to kind of have a moment where we stop and think about why we became practitioners in the first place, whether you are a mental health therapist, whether you are an educator, whether you are doing research of your own, whether you're in the medical field. So again, theoretically, a lot of people become practitioners because they want to help. So while it may seem unnecessary to even cover this in a training, and again, to a certain extent, many of you who choose to listen to me discuss this topic are probably open to strategies for reflection and personal growth, but I think it's important to take a moment to really ask ourselves this before we delve in. Whether you're new to the helping field, whether you've been a therapist or counselor for 10 or 20 years, or whether you've lost count because you're drowning in community mental health paperwork and you're only doing this because you need some CEUs, which is totally fine, by the way. Again, why do we decide to help? What makes us continue to want to help? Did you know exactly who you wanted to help going into the field that you're in? Was there any population that you were concerned with helping? Maybe you were already pretty aware of certain biases that you had, or maybe had some preconceived notions about what helping would be like, particularly if you're working for, community mental health where, again, typically clinicians are vastly underpaid, the hours are really long, the clientele, and their symptomatology is, extremely, extremely, severe at times. And so again, these are all really important factors to consider because they may impact the day-to-day work that we do with our clients. And definitely our implicit biases, can grow and sometimes become much stronger when you're feeling depleted and overworked. So, definitely take a couple moments and, jot down some thoughts and things here where, maybe you haven't thought about this in a long time, but think about it for a second and, have it in mind as we move forward in this discussion. And I know for me personally, I'm Cambodian American. My family, they were refugees during the Khmer Rouge genocide. And that has always been my sort of general, go-to response anytime that question has been asked of me, maybe like in an interview for a position in terms of why I was interested in mental health coming into this field. And it really took many, many years for me to understand that, there needs to be a voice for not just minority populations in the field as well as clients, but also with regards to this discussion about culture and how we are integrating cultural competence in the field. And I know for me, just not having exposure to that much research on it, just made it so that it was something that I didn't feel, I felt like it had been addressed as much as it could be, when you're in grad school. Maybe you learn a little bit about it. I was very lucky to have, really amazing professors, in my grad school courses that really made the topic about self-reflection. And so that was something that I carried with me into my practice, and it's really grown since then. So, my hope is that, again, this is something that continues to grow, that we can continue to be in discussion about, just because, again, there's so much, that we don't realize, we impact when we work with clients, and it can be very concerning, not having any sort of awareness that sometimes our own biases that we don't know we have are really negatively affecting the people that we are wanting to help the most. Okay, so now we're going to get into discussion about cultural competence as well as cultural humility. To clarify, I'm not really going to focus on just one definition each, for these concepts, kind of like I discussed before. Again, rather, I'd like to get into a discussion about how these definitions have transformed over time and impacted our practice. So to start off, I'll provide some formal definitions of cultural competence presented by different agencies and literature prior to getting into further explanation of the concept. So, for example, the Substance Abuse and Mental Health Services Administration, SAMHSA, they define cultural competence essentially as the ability to interact effectively with people of different cultures and ensuring the needs of all community members are addressed. SAMHSA then elaborates, and they do a really great job of outlining how cultural competence should be implemented systematically for organizations serving diverse populations, such as, with the continued assessment of organizational diversity and building capacity for cultural inclusion. Now, let's talk about what actually comes to mind for many new clinicians when we discuss cultural competence. So in speaking with many new therapists, I found that their idea of cultural competence was much more simplistic, again, through no fault of their own. It's this idea that in the helping field, we should do our research when it comes to working with clients of diverse backgrounds and be prepared to assert how, quote, cultured we are or how well-versed we are in the culture of another person. This perspective really stems from times where cultural considerations were just making their way into the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, as you guys are probably aware, which continues to be a work in progress. Again, for those of you who are in the mental health field, you're probably very well versed, in using the DSM, maybe know a little bit about the history. It wasn't really until I can't remember which DSM edition it was, but for example, homosexuality, as many of you may know, was in the DSM as a mental disorder, and it took a lot of advocacy, a lot of time for that to be removed, which was not that long ago. Cultural assessments, again, that I think it wasn't until the DSM 4TR that there was an outline of an assessment there in relation to disorders in the context of cultures, and the DSM-5 has since elaborated on that, but again, we are still a really a long way from really finding some sort of, policy or procedure that can help us integrate cultural competence into our work. There's really nothing formal that assists with that at this point. There's this idea that, practitioners should and need to be culturally competent in their practices, but again, little to no structure on how that should be implemented. So one strategy is that therapists were to assert cultural competence in an attempt to build rapport with clients. Again, while this strategy in and of itself isn't overtly harmful, it can be very limiting. Cultural competence really isn't a test of how much knowledge you have over another person's culture. So another way to look at cultural competence by definition is, basically a combination of 1, awareness of our cultural biases, 2, having knowledge of the diverse cultural groups we work with in our practice, and 3, acquiring the skills to assist in the common goal of advocating for clients of a diverse background. So if any of you are familiar with Drs. Daryl Wing Su and Dr. David Su, they are the authors of Counseling the Culturally Diverse, which is a textbook that's used often in many classes that teach multicultural counseling. They provide the following definition, which is one that I really like. Cultural competence is the ability to engage in actions or create conditions that maximize the optimal development of client and client systems. Multicultural counseling competence is defined as the counselor's acquisition of awareness, knowledge, and the skills needed to function effectively in a pluralistic democratic society. So the ability to communicate, interact, negotiate, and intervene on behalf of clients from diverse backgrounds, and on an organizational and societal level, advocating effectively to develop new theories, practices, policies, and organizational structures that are more responsive to all groups. I actually had the opportunity to listen to Dr. Daryl Wing Su speak. Definitely, if anyone ever has a chance, to listen to him, it's really, really amazing, again, just to kind of, read this book that, in some senses was so progressive, and even more so in him writing it, back in the day. The discussion piece that resonated with me the most was where Dr. Su emphasized really how frustrated he was that the focus within clinical work is still on cultural competence rather than cultural humility, which we'll get into. That even if we don't mean to, clinicians tend to present themselves as experts and view cases as though our clients should fit into our clinical protocols and models, not the other way around. So this is, in talking about, how we're defining cultural competence, this is kind of a good example of the limitations of that. For those of you who have ever done community mental health work, know all about evidence-based practices, all about funding issues and how, again, not necessarily like through any fault of, the actual agencies that you work for. They're very limited in terms of how we can treat the clients in the community that really need our services the most. And, some of the problems with these types of agencies is that they're sort of like we need to make people sort of fit into our model versus meeting the needs of the clients. Some programs do really well, with the flexibility of that. But again, we always have to consider, are we doing right by our clients in the way that we are conceptualizing them, in the way that we're viewing them, in the way that they are adhering to the models that we're using. So it's just something to think about there. And so cultural humility basically takes all of those definitions, all the definitions of cultural competence, and essentially views it through an other-oriented lens. One definition that I really like comes from the Journal of Counseling Psychology. They define it as cultural humility is basically having an interpersonal stance that is other-oriented rather than self-focused, characterized by respect and lack of superiority toward an individual's cultural background and experience. So really the main difference between the lens of cultural humility and general cultural competence is that cultural humility focuses on taking a one-down approach, that we are not the experts, that we are not the superiors. We don't expect that our clients teach us their culture, even though many clinicians assume that this is the expectation, and they kind of, newer therapists tend to go in, and you work with clients saying, okay, teach me all about your background because I'm not aware of it, and they think in that way they're being respectful, and they're trying, but again, this takes practice. Really, cultural humility means that we need to come from a place of recognizing our own internal process when working with a client of any background, and understand how we react to others. The question then becomes, is one more effective in practice than the other? My answer is that I think you need both. Practitioners have an ethical responsibility to ensure cultural competence in their practice. In mental health, this includes seeking supervision and guidance when clinicians are struggling to treat clients in culturally respectful ways. Cultural humility is an approach that reinforces collaboration and communication between the practitioner and the client rather than directive discussion to understand their contextual origins and how these experiences might play into their reason for referral. So by taking a one-down approach, we can be more authentic in discussions and gain and understand more than we would by basically making assumptions. So how does all this tie into our own client care and with clinical interviewing specifically? One example right off the bat are our phone screenings. So let's say that, let's say you're working for an agency, and sometimes you have phone screenings, you have, maybe staff that kind of, screens, the clients either walking in or calling who are seeking services. Basically a referral source. Usually these have some sort of demographic information. Usually it'll say, hey, client is 11-year-old little Johnny. He is like Mexican American, blah, blah, blah. It'll give you like a list of information. Demographic information is often provided, and when it is, it can be so helpful, but also so harmful, depending on how we use this information. Again, you typically see a name, maybe an ethnicity, whether it's accurate or not, who knows? That's the other thing, right? Again, sometimes we make assumptions before even meeting the clients. And then basically it'll list symptoms or behaviors that are listed. Maybe you're a clinician that does your own phone screenings and consultation calls. So again, even more important to get accurate information here and really reflect on how we're using this. So now we have all this information. We haven't met little Johnny yet. What do our minds tend to do with that information? Again, this is a great segue into the discussion that we're going to have about implicit racial bias, but really take a second here and think about if you are a therapist, or if you're in the medical field, and again, you're seeing information on paper about a client, and you see a name. Maybe that name seems like a typical American name. Maybe the name you're making an assumption about where this person has grown up. You're making an assumption about level of immigration. Maybe you're not thinking about any of this at all. But something is happening when you're looking at this name and you're looking at their ethnicity, and, your brain is filtering. Your brain is, putting things into groups as it does. And so again, it's not so much about catching and developing a strategy here for these types of processes, but just being aware that sometimes we are judging even before meeting with the client or the patient, that we have preconceived notions already, and we want to really recognize that regularly. so that we begin to understand how this might affect our work with them and the service that we're providing to them. So I'm going to briefly talk about some definitions for both bias and implicit bias. Again, pretty straightforward, as most of you know. Bias is basically prejudice, basically favoring or unfavoring, maybe a person or a group. Some examples of this would be, let's say in terms of, if we're talking about overt bias, obvious bias. I currently do a mediation for the court system, and again, that's typically two people, right? You typically have a mother and a father. You don't know a whole lot about them, and they're talking about pretty difficult things in terms of spending and sharing time with their children. Lots of bias here, right? Because you have a lot of information, and you have to work really quickly in terms of sorting out the information that is being provided to you, and sometimes it's a lot of difficult information to take in. And depending on whether you're meeting with them conjointly or individually, you may have bias in terms of favoring or siding with moms more, or doing so with dads more. Those are all some examples, but again, also kind of bleeds into implicit bias when you're not so aware. So implicit bias is basically unconscious bias, and this is essentially when the bias is outside of our own conscious awareness. This is the sort of bias that can become very dangerous, right? So when we say things like, I'm not a racist, right? Anytime, you ever get accused of being racist, a lot of people, that's kind of like the go-to thing. I'm not a racist. I have friends of all sorts of backgrounds, The thing is, we all have some sort of opinion, whether we're sharing it or not, whether we're aware of it or not. Our brain is trying to group and filter information all the time. It's trying to make sense of things. And so part of this discussion is kind of a challenge of, can we shift our discussion into holding ourselves accountable and being able to say, I do have biases, and I wonder if I have, some implicit biases. I wonder if I have unconscious biases that I'm not aware of. And I wonder what that's doing in terms of my day-to-day life. I wonder what that's doing in work. And I wonder what that's doing if I'm working in the helping field. I wanted to give some examples as we went into the discussion regarding the implications of bias when working with diverse clients. I know a few years ago, I worked with a client. He was a male 7-year-old, very energetic, very, 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 very energetic. He, I think originally was referred by his school. And the way that they described this little boy, I'll never forget, it made him sound like he was about 8 feet tall. I know that, the principal, and again, this is, according to, the caregiver indicated that he felt threatened. This principal was actually, big, 6 feet tall, I was confused. So it was very much like, okay, well, again, sometimes kids can be scary. I wonder, what their concerns are. And, they had issues with, him having difficulty regulating his temperament. They felt that he was aggressive. They felt that he threw tantrums, that he was a disruption in school. And I met with this client. He happened to be an African-American male. And I would say the most salient memories I have of working with him are actually the times where I would retrieve him from the school office and then have to walk across the entire school basically to use a classroom in order to do a therapy session. It wasn't so much like the sessions that I remember the most, but I think the times where there was one time in particular where we had to walk a little bit further, and I think it just so happened to be a time, when recess was ending. There was a lot of staff outside, and again, like I said, he was very energetic. He was walking along short little, ledges, things that border flower pots and things like that. And I just remember feeling as though he was completely targeted. Now, again, this could be that because he had, had so many behaviors previously, had been sent to the office before he was very well known. However, at this point, we had been working together for a few months now, and his behaviors were actually reducing. Generally, he was improving. I was consulting with his teachers and the staff, but it was really interesting to see staff snapping their fingers at him. The tone that they were using with him was very demanding. And at that moment, I think I looked around and I saw other children that were just as energetic, that were doing similar behaviors. And again, this is not to excuse his behaviors. So some of his behaviors were definitely difficult, and this isn't brought up to excuse them. But, I had several clients at this particular school who all exhibited similar behaviors in terms of frequency and intensity, similar symptomatology. And at the end of the day, can I really say for certain and on behalf of the client that race and the color of his skin had anything to do with how he was being treated? Of course, I can't say that. I can't prove it, but it is my duty, and it's important, for me, and it was important for me then to really stop and think about whether this was something that had been addressed. Had it, been brought up? Was it being taken into consideration? Was I doing a good job being culturally competent and, bringing the discussion past, again, the demographic information of this is a 7-year-old African American male exhibiting symptoms of blah, 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 blah. There was something bigger there, and really it was important for me to address that, with him, the family, my superiors, right? My supervisor, bringing it up in clinical supervision, and the staff, and really trying to understand, okay, but why are we treating him differently? Especially when I had clients, other clients who really on paper were very, very similar. And I noticed that, staff treated them very differently. So again, it's not that I was needing, some sort of immediate solution, but I kind of just wanted to assess and see what is everyone's level of awareness, everyone who's working with this child, everyone who is involved in this child's life, everyone who plays a part in assisting this child. Are we providing him with the right kind of care? Are we being aware of our own biases and really understanding why we are a little bit, more, I guess, for some of the staff, the ones that I had observed that day, why was it okay to be more disrespectful to him, to be more aggressive towards him? And why didn't I see that whenever I walked, with other clients who were doing the same sorts of behaviors from the same staff? I also worked at a homeless shelter on Skid Row. For those of you that are not familiar with the area, Skid Row is a small area in downtown Los Angeles that people are really suffering from chronic homelessness there. Is a lot of shelters there, but definitely not enough. I felt very lucky to have experienced there. One of my first experiences clinically, working at a homeless shelter, but just really wishing, there were more housing, more resources, for the people there. So I worked primarily with adults, in this area, and the people were getting diagnosed with schizophrenia left and right, which is in and of itself a diagnosis that is complex. And I think the most concerning thing, and especially with this being, one of the first therapy experiences I ever had, was that no one was ever stopping to consider, that a person may have gone through extreme duress, extreme trauma. Again, the stories that my clients told me they were indicative of multi-generational trauma. And I felt as though there was just so much there that concerned me in terms of, not enough consideration, that, maybe we were being too simplistic with our diagnostic mechanisms. Now, what does race play a role in this? I don't know if anyone could ever prove that it does, but Skid Row has a significant homeless population. There's a lot of African American males, a lot of people who have history of incarceration. Now, again, this is really where our biases come in, right? Especially, as we discuss this, especially with everything, that's going on, that you see in the news with law enforcement, the release of body cam footage and things of that nature. The discussion always seems to be very controversial, but there's not enough discussion really on the history of where this comes from. I know that it seemed to be that, many residents of Skid Row often had a lot of blame placed on them for being in the position, that they were in. Again, chronic homelessness, chronic substance use, severe mental health issues. And I remember even, amongst my peers and colleagues, getting a lot of judgment for even wanting to, do my traineeship at a homeless shelter. Again, you have to wonder, where do these feelings come from? I would say it's really easy for people, to just look at surface level behaviors and not look at the history, right? The history of, this nation being founded in racism and slavery. And again, thinking about the progression over time of the treatment of African Americans. It's something, for everyone, and especially for practitioners, working with clients of color, to take this into consideration, to take the context into consideration for cultural considerations, and really understand the context of what minorities and people of color have to go through. And I know for me, being immersed in that in a clinical setting, was very eye-opening. And I think, again, really having the privilege of sitting down one-on-one, with someone and hearing their story and helping them also get to an understanding of, where they're at today, and helping me get to an understanding, helping me keep myself in check, helping me learn about my own biases. Again, it was a very, very, significant time. And I think, again, this is part of why having these ongoing discussions is really important. At the end of the day, it's really hard to prove that people are being treated unfairly, right? There's this idea that everyone is equal. There's this idea, that there's a colorblind approach, that, everyone has equal rights now. We have the civil rights movement. Thusly, everyone should have moved past history and all that. The problem with that, again, comes down to the fact that we can't really change our physical characteristics, and whether we like it or not, what we look like plays a factor in how we treat each other. And as clinicians, this is especially important, because, again, having our unconscious biases play a role in how we conceptualize our clients and how we diagnose clients can have serious implications for their treatment, serious implications for consultations with psychiatrists, and the prescription of medication. Another example I want to bring up is there was a time when I was working in a community mental health program that was very basically the whatever works policy. We had a lot of clients who had some pretty severe symptomatology. We had 24/7 crisis call. I had a client who was in his mid-20s. He was an African-American male, probably at least 6 feet tall. He, I think, had regional center services, was diagnosed with fetal alcohol syndrome, and I feel also may have been, on the autism spectrum, but he had a lot of multimodal services just for some of the different things, that he presented with. And I remember this client the most, in part because so he was residing in a housing program for people with developmental disabilities, and I remember that even though he was in his mid-20s, we really spoke, in a way where he kind of presented a lot younger cognitively and emotionally. He had very childlike mannerisms and liked to play around a lot. The problem is that there were times where, he would, get in trouble a lot. He would escalate. He would get very angry, and he would be hospitalized quite frequently. I think when I started working with him, he was being hospitalized over 10 times per year. He was being 5150'd. I remember that the area that this client resided in, so the actual home, for people with disabilities, that he lived with, it was in this very nice suburban area. And every single time, I got a crisis call, I'd be like, oh man, the neighbors were always out there staring at me, coming at me, trying to get information from me that was confidential. I never said who I was or why I was there, because at the end of the day, it wasn't any of their business. And again, it's not as though my client had ever done anything to them. But it was almost as if, some of these neighbors, who happened to be, a little bit older, I got the sense that they were, maybe a little bit upset. Their houses, some of them told me they'd been there for a long time. It just got the sense that they didn't like that there was a house, in their neighborhood. And I remember, they would make accusations towards him of things where, again, they didn't even know, if he had done anything. But anytime, the police officers or the ambulance came for him for assessment purposes, they would throw the accusations out there. And again, we have to ask ourselves now, if he were not an African American male, who's a really tall guy, would their reaction be the same? Would they make these accusations of, him stealing things and things of that nature, things that, just, again, were coming out of left field, things that they were saying to me, this stranger. And I saw that again and again and again, where, again, I had clients who had similar symptomatology, and, the responses and reactions, from the community were very, very different. And so what does the research tell us? There's a couple of articles that I wanted to refer to that I'll cite elsewhere, really focused more on studies that were done in the medical field. There's one from the American Journal of Public Health, entitled "The Associations of Clinicians' Implicit Attitudes About Race with Medical Visit Communication and Patient Ratings of Interpersonal Care." And basically, their research examined the associations of clinicians' implicit attitudes about race with visit communication and, again, patient ratings of care. They concluded that clinician implicit race bias and race and compliance stereotyping are associated with markers of poor visit communication and poor ratings of care, particularly among Black Americans. They talk a lot about bias and unconscious biases, and really, again, focus on how actually there's little work that's examined how clinicians' implicit racial attitudes affect communication and patient experiences in actual medical encounters. So again, just kind of something to think about. This was, I think, published in 2012, just not that long ago. There just hasn't been a lot of studies in general that have been conducted on this. There's also another article entitled "Clinicians' Implicit Ethnic and Racial Bias and Perceptions of Care Among Black and Latino Patients." What they did was investigate whether clinicians' explicit and implicit ethnic and racial bias is related to Black and Latino patients' perceptions of their care in established clinical relationships. And they also noted that, this is one of the first studies to investigate clinicians' implicit bias and communication processes in ongoing clinical relationships. And, their findings suggested that clinicians' implicit bias might jeopardize their clinical relationships with Black patients, and could have negative effects on other care processes. So I think what's important in a lot of the research that's out there is that, again, this is about accountability on us as clinicians. These findings are actually quite concerning because we're in the helping field. And so, in thinking that, we want to help underserved populations, we might actually be doing more harm by not being aware and not holding ourselves accountable to some of the internal processes, that may be biased. So I wanted to do a visualization exercise just to kind of get us to be able to reflect a little bit more. I'm going to describe some features and information about a client, that I had. And I just want you to sort of visualize as I speak. So this client is a 12-year-old male who plays baseball. He exhibits difficulty focusing in class, difficulty refraining from talking when he's not supposed to be talking in class, difficulty maintaining interpersonal relationships, often engages in fights at school, difficulty regulating his mood, so on and so forth. So first, when I mentioned these symptoms, did you think about a specific client maybe you've had? If so, what was the ethnic background and diagnosis that you or another clinician provided? And if not, what was the ethnic background of the client that you envisioned for this person? And with that person in mind, what diagnosis did your mind immediately jump to? And so I bring this up because, I've actually had, several clients who meet this criteria, but I had two specifically, kind of around the same time where, again, both played the same sports, pretty much the same age, pretty much, similar behaviors and symptoms. One of the clients had been diagnosed with ADHD, and the other client was diagnosed with many things over the years, oppositional defiant disorder, conduct disorder at one point, intermittent explosive disorder, and again, the ethnic background of the second boy was African American, and the first boy was not. Not to say again that again there weren't other confounding factors that contributed to client number two's diagnoses. However, it is something to take into consideration, where again, without meeting this client, without me telling you the ethnic background of the client, we have no visual. It's really interesting to see what our mind does with that, and whether having that demographic information changes our diagnosis is really significant. Because from a clinical perspective, a lot of these symptoms are newer and kind of complex in and of themselves. A lot of them in young children look very similar. When you think about ADHD and PTSD, when you think about, let's say for adults, bipolar disorder, again, not that long ago when there was childhood bipolar disorder, and all these different diagnoses, a lot, anxiety, depression, all of these symptoms in young children, there's a lot of overlap, there's a lot of commonalities, and we as clinicians have a responsibility to ensure that when we're making professional diagnoses, that we're really giving all of our clients a fair chance. And we're making sure that we're doing our due diligence. Is hard. It's hard in community mental health, for example, when you sort of feel like you have to diagnose within 24 hours. And so you do have to make assumptions very quickly. But it is our ethical responsibility to go back and amend that and change that, and to always be assessing if we're feeling as though, okay, now that I have more information, I think I need to amend this. Maybe I was a little bit biased in the beginning, and now that I've, kind of gotten to know the child and family and the context with which he lives in a little bit more, I think this is a more appropriate diagnosis. The issues occur when we don't go and do that, and we go along, with our assumptions, and we think certain clients of certain backgrounds, tend to exhibit certain diagnoses more. Again, have the conversation, seek guidance, seek supervision, question yourself, be curious, and, be that person, that does their due diligence and really wants to have that discussion over and over and over again as much as you can. So lastly, I just wanted to get into some strategies to sort of help us be better clinicians and, be more mindful of our cultural competency and cultural humility practices. Really, these are more posing questions than anything else rather than specifically strategies. But again, that's kind of the point. Reflect. The first thing I want to bring up again, as I've reiterated, is accountability, take accountability. This is really good clinical practice for any issue. Oh, I could have handled that better. I was a little unprepared for that case. I'm feeling really triggered by this client. And explore where that countertransference is coming from, especially if it's a first encounter and, after the intake session, you feel like immediately you've made judgments, and maybe it's because of how they looked, maybe it's because of their ethnic and cultural background, maybe it's because of a linguistics issue, whatever it is. Take accountability, because that is really where the most growth occurs, is when you take accountability for something rather than just kind of, sweeping it under the rug. Secondly, I would definitely encourage, as a strategy and practice, exploring the policies, the procedures, and any protocols of your place of employment, anything that they have to address culture. So most companies, they'll cite their equal employment opportunity policies in some form, but these policies are rarely discussed or processed with employees. Cultural competence and cultural humility approaches are often, assumed to be more of an ethical responsibility rather than a legal mandate. In other words, you're not allowed to be discriminatory, but you may have no clue that you are discriminating or acting in a biased way. So even though the legal policy is there, again, remember, we want to take it a step further. And if we're going to be employed by any sort of overarching structure, we also want to hold that agency accountable as well. I'd also recommend really conducting your own reflection practices regularly, just as we've done, throughout this talk, especially if you feel as though, your place of employment lacks an effective system or protocol that addresses issues of cultural competence and diversity. The whole point of implicit bias is that it starts from within. If you're overwhelmed at the thought of challenging an organization, remember that there are many ways to make an impact. So if you're more of a small splash person rather than, someone who enjoys making big waves, making a big scene, this is your time to shine. You can make an impact by making sure you're engaging in self-reflection, as well as, asking challenging or reflective questions of your colleagues, peers, and your superiors as well. If you're a more didactic person, you can absolutely, make a ripple effect here and really instigate change. Some questions to ask, one, what are my biases in working, with this population? What was happening for me internally as I was talking to this person? And even if I had positive biases, right? Does my perception of this person based on their physical appearance cloud my diagnostic impression? So again, it can work the other way, where maybe because of a positive bias that we have, or positive stereotyping that we're doing, we are neglecting to see, serious diagnostic implications, because it's clouding our judgment and skewing our perception. Lastly, do your research. Take the implicit attitudes test, the IAT, that's been around for a while, and question it. Take it and you see what you think, and, identify, any holes that you see in the way that they, put out the test. Do whatever you can to basically expose yourself more to the discussion of implicit bias. Be curious, be skeptical, find ways to integrate culture into your personal and professional discussion until it becomes the standard. Turn the phrase, "I'm not a racist," into everyone holds conscious and unconscious personal beliefs. And as practitioners, we have an ethical responsibility to ensure that we hold ourselves accountable in making sure that we grow awareness of these things. So that concludes this discussion on impact of implicit racial bias in mental health settings for practitioners. I want to thank all of you for listening. Hope it was somewhat helpful. And again, hopefully it just helped to engender some discussion for you.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need Continuing Ed credits, please visit us at clearlyclinical.com to check out our one-year membership, where you'll have access to our growing library of Continuing Ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.